Hey guys, it's Miss Turner. So this is going to be your last video for the year. So this is going to be head to toe assessment and walking you through all the pieces of it. I just want to show you a few of the papers that you're going to get when you come to lab. So you're going to get a report sheet. For practice, you're not going to actually get a report on a patient, but for your test out piece, you will be getting a report on a patient, and then you'll have to go in and take care of your patient. You're going to get a head to toe assessment rubric. So this is going to show you exactly how you're going to be graded. You need to get an 80% on this to be successful. If you don't get an 80% on it, you get another time or another opportunity to do it, just like you have with every other skill. If you're still not successful, then you're placed on clinical probation. You're also going to get a head to toe assessment worksheet to practice with, okay? And I want you to bring your clinical pathway with you, and that is how you can practice any of your documentation. When you come for test out, we're going to give you a separate packet to actually document in, but it's all of the same pieces that are in your pathway. We've just kind of condensed it down here so we don't have to make a million paper copies. Okay, so supplies you're going to need to do your head to toe assessment are pulse oximeter, a stethoscope, thermometer, blood pressure cuff so you can do a set of vitals. You're also going to need an IV flush because you're going to be assessing an IV. Then at the end of what I'm going to show you, I'm going to talk about some of the other skills that you might need to demonstrate during this. But for a minimum, everyone's going to need enough supplies to do vitals and to do an IV flush. So I'm just going to get started. I'm going to go in and see my patient and just walk you through, how I would do head to toe assessment. Now, there isn't just one way in which you can do this. Of course, there's a million different ways you can do it. I think the more organized you are, the better. So I really like to start from head to toe and work my way down when I get to that piece of it. I'm going to start with AIDIT, of course. I'm going to go in, do AIDIT. I'm going to do my set of vitals. I'm going to do my assessment. Then I'm going to do my IV flush. Then you'll have to prioritize amongst the other skills you have. Everyone's going to have to do a med pass, and then you're going to have 2 other skills you're going to have to do. For lab practice, we're going to have all the skills out in the lab, so you'll just be able to practice during that time. For your head to toe assessment, you won't know which 2 skills you're going to get on top of medication administration. But once you're done with your AIDIT, your vitals, your head to toe assessment, your IV flush, you'll then have to prioritize, okay, I have medication administration to do, I have to change a dressing, and I need to put restraints on my patient. Which order should I do those in, and how should I go about doing that? Okay, I'm going to show you just the main chunk of it. Okay, so let's go in and see our patient. So knock, knock, knock. Hi, Mrs. Smith. I'm Shayna. I'm going to be your student nurse today. I'm here to do a set of vital signs on you, take your blood pressure, take your heart rate, those types of things. And then I'm also going to do a quick assessment. So I'm going to listen to your lungs, to your belly. I'm going to look at your feet and make sure everything looks okay. Then I'm going to look at your IV, make sure that looks okay. And I'm going to go get your medications for this morning. It should take me about 20 or 30 minutes, and then I'll be out of your hair. So, Ms. Smith, the first thing I'm going to do is just check your wristband. I'm going to ask you if you can tell me your name and date of birth. Patient repeats. I also would check to see if they had an allergy band on at that point that matched what the kind of nurse had told me. Also, when I walk into the room, I'm just going to be doing a general kind of survey of the environment. Does everything appear as if what the nurse told me in report? If they are supposed to be on oxygen, are they on oxygen? If they're supposed to have IV fluids going, are they on IV fluids? Those sorts of things. All right, Mrs. Smith, so I'm going to take your blood pressure first. My simulation mannequin here already has her cuff on. So I'm going to go through and take her blood pressure. Of course, when you're doing this, you're going to be palpating for the brachial artery. My simulation mannequin does not have a palpable brachial artery. But for your patients, for your head to toe assessment, anytime you're doing vitals, you should be palpating for that brachial artery. Okay, Ms. Smith, your blood pressure is 120 on 80, so that is good. So I'm just going to feel for your heart rate here on your arm. I'm going to put the side rail down just to facilitate it a little bit. I also can put the bed up a little bit to help me. feel for her pulse. I'm going to count it for 30 seconds if it's regular, a minute if it's irregular. Then I'm going to immediately go to watch her chest rise and fall. My simulation mannequin does not, but you're going to have real patients whose chest does rise and fall. So I'm going to pretend that I'm still feeling for her pulse. I'm going to count her respiratory rates. Okay, so now I'm taking her heart rate for 30 seconds, multiplied times 2. Taking her respiratory rate for 30 seconds, multiplied times 2. Okay, Mrs. Smith, everything seems good. Just going to put this probe on the end of your finger to check your oxygen. I'm going to leave that on for about 10 or 15 seconds until I get a nice consistent number reading on that. In the meantime, I could take her temperature as well. Ms. Smith, I'm going to put this under your tongue. I'm going to ask you to close your mouth completely around it until it beeps. I'm going to turn it on, put it in the sac on the side of her mouth, kind of under her tongue there, and I'm going to ask her to close her mouth, and then it's going to beep. Okay, Mrs. Smith, that looks good. Oxygen saturation now has a nice reading, and that is good. So I've completed a full set of vitals at this point, and now I'm going to go on to do my head-to-toe assessment. So Mrs. Smith, I'm going to take a listen to your lungs first. Actually, before I get started with that, I just want to ask you a couple of questions. I already asked you to tell me what your name and date of birth, but I also want to know if you can tell me where you are, and if you can tell me what the date is, or what day of the week it is. So now I've assessed her neurological status as Sheila and oriented times 3. I'm going to kind of move down the mannequin at this point. My simulation mannequin, you can only listen anteriorly, but for test out, you're going to listen both anterior and posterior. So I'm going to start and ask my mannequin or my patient to sit forward. I would listen posteriorly first. So I would sit my patient up. Hopefully they can kind of hold themselves up. And I'm going to listen to their posterior lung sounds. Asking them to take a nice deep breath every time I move my stethoscope. So Mrs. Smith, you can just take a nice deep breath every time I move my stethoscope. I'm going to start up at the top, and I move my way down her back. So what I'm doing is going down her back like this. Here, move over, down, over, okay? Then you go out a little bit, okay? Down the front of the chest, I'm gonna listen up here, and I'm gonna move in a little bit farther. So you can listen down the front of the chest. The back of the chest is where you're gonna hear the best lung sounds. You're gonna hear the lung fields completely on the back. So after I'm done listening to the front of her lung sounds, you may need to give your patient a break in between that. It's a lot of breaths for them to take. I'm going to go down and I'm going to listen to the heart. So I'm going to count down to the 5th intercostal space. I'm going to move over mid-clavicular, and I'm going to put my stethoscope there, and I'm going to count the apical pulse for 1 full minute. I'm going to be assessing, is it regular, is it irregular, and do I happen to note any extra abnormalities while I'm listening. Okay, Mrs. Smith, your heart and lungs sound really good. I'm going to go down and take a listen to your belly now. I'm going to pull up your gown, just expose your patient where needed. Divide the abdomen into 4 quadrants, okay? And I'm going to listen in each quadrant. I'm just going to move this for camera purposes, but you wouldn't expose your patient that much. So I'm going to listen in each quadrant until I hear something. You don't have to listen in each quadrant for a certain amount of time. You just want to listen till you hear something. If it takes you more towards a minute till you hear something, you're going to consider those more hypoactive bowel sounds. Otherwise, you should be hearing something, I would say, within 20 or 30 seconds and fairly regularly. If it's more frequently than that, you put your stethoscope down and it's like gurgle, 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 kind of like nonstop. That's you're going to consider the patient has hyperactive bowel sounds. So I'm always going to listen first before I feel the abdomen. Once I listen in all 4 quadrants, I then can palpate the abdomen so I can assess, does it look distended? Does it look flat? I can ask the patient while I'm very mildly palpating, do they feel any pain or tenderness? So then you'll classify your abdomen as bowel sounds positive in all 4 quadrants, non-distended, non-tender, and that was what we would consider a normal abdominal assessment. All right, Ms. Smith, everything looks good with your belly. I'm going to compare pulses in her arms. So I already counted the pulse rate over here, so I'm not counting. Again, I'm just going to feel both sides, and I'm going to compare them. Do they feel the same on each side? Do they feel regular on each side? Are they even and equal? Are they +1, +2, or +3? +2 is pretty normal. +1 would be what we consider a thready pulse. Sometimes as new practitioners, people automatically think that everyone's pulse is thready, but it's really, we haven't trained our fingers well enough to really feel those pulses. If someone's pulse is thready, they're probably very, very, very sick and very, very unstable. If it's bounding, we're going to think more the patient's kind of fluid overloaded or they're very hypertensive, and that's really, really strong, palpable pulse. Okay? I'm going to ask Ms. Smith just a couple of questions about her belly and her urinary system. So I want to ask her when the last time she moved her bowels was. Was it normal? What color was it? Was it loose? Was it soft? Was it formed? All of those questions. How many times does she normally go? So if she tells you it's been 3 days since she went, and you were kind of like, oh my God, it's been so long. If she tells you I only normally go twice a week, well then that's the norm for her. So sometimes you got to follow those questions up before we make assumptions that it's abnormal. I also want to ask her when the last time she voided was that normal? Did she have any pain? Did it have any odor? I would want to assess that myself if I could. If I had access to that, I would ask her to save it so I could look at it myself. I'm going to move down. I'm going to assess her legs and her feet. So if she had STD sleeves on, I would take those off, and I would assess the legs for edema. So I would start right at the foot, and I would push kind of right up the shin to see if she has any edema in her legs. Mrs. Smith does not, but if a patient did, you would classify it +1, +2, +3. There isn't kind of like a gold standard for that. Everyone's going to be a little objective in it. +1, I usually say you push in, you see a print in their skin, but it almost instantaneously comes back, or within a few seconds, you can no longer see your fingers. +2 is going to be a little bit longer, so maybe that stays 5 or 10 seconds. +3 and +4 are going to be, +3 maybe a minute later you come back and it's finally gone. Sometimes I've had patients, I come back 10 minutes later and I can still see where I've pushed into their legs. So you'll get a little bit more accustomed to what all of those things mean the more experience you have. At this point, I could also assess for Homan signs, so I could push her foot up, ask her if she has any pain in her calf, any tenderness in her calf. I could do that on both sides. At this point, I would also palpate her pedal pulses. So again, we're not counting it. We don't care what the number is. We just want to assess both sides. Are they even and equal? Does she have circulation in all of her extremities? So I already checked her arms, and now I'm checking her feet, okay? If I couldn't feel a pedal pulse, I might get a Doppler to assist me in that, or I would move my way up. So then I could palpate here around the ankle, or I could go up and assess the popliteal pulse to make sure to see where I could feel that pulse. But usually we want it to be all the way down into the foot. So if you couldn't palpate a pedal pulse, you would go get a Doppler and you would actually listen to see if you could hear that pedal pulse. I would also ask Mrs. Smith about her pain level. So Mrs. Smith, do you have any pain? Can you rate it for me on a scale of 0 to 10, 0 being no pain, 10 being the worst pain? You may do that when you do your vitals. Sometimes I do. It needs to happen at some point. Sometimes it feels kind of more comfortable to do it when you're doing your vitals. I want to ask her to describe the pain. Where is the pain? You can ask, does anything make the pain better? Does anything make the pain worse? You can ask all those sorts of questions, but most importantly, we want to know if that pain is okay for her. So even if she's rating it a 7, we still have to say, okay, is that pain okay for you? Or do you need me to, do something, or to help you do something about that pain and intervene in some sort of way? When you're doing your head to toe assessment as well, you of course always do a skin assessment. So you would inspect all areas of the skin. Usually during vital signs, you're inspecting the arms. When you're doing your listening, you're inspecting the chest and the belly. And then when you're doing your feet and your leg assessment, you're inspecting the legs. The only other thing that I would recommend you do is to turn your patient over and assess the sacral area. Now, of course, not every patient is at 100% pertinent on you. You have an independent 25-year-old who's, post-op day 1 who's going to be discharged. I might not ask her to see her sacral area, but any patient, especially who's been in the hospital for a period of time and, of course, spends more time in their bed than outside of their bed, I definitely want to take a peek at that sacral area to make sure that it looks okay and it's not getting red. At this point, I am going to go over and I'm going to flush my IV. So I'm going to take my supplies, my flush, my alcohol swabs. I'm going to put some gloves on. IV site is good for 4 days, so 96 hours. So you want to make sure that your IV hasn't been in longer than that or it needs to be changed. I'm going to open my package. I'm going to assemble my IV flush. I'm going to screw off the top part. Open